again. Illinois Pharmacy Legislative Day 2017. What are you supposed to know? Thanks for dialing in today, and we hope that if you listen to this later on online that it's of value to you before you get to Legislative Day. So first things first, one of the things that you need to know that's critical is who your state senator and state representative are. You can look those up on this link that I have here, or you can just go to the ICHP website at www.ichpnet.org and then click under Pharmacy Practice. You'll see Advocacy, and then look for the Advocacy Center. You'll need to add your zip code first and then your street address, because it seems none of the legislative districts are divided by full zip code addresses. So find your senator and your representative, and that will help you later on. Also, once you've gone through this, it doesn't hurt to give your senator and your representative a call down in Springfield to their office. Ask their secretary what time during the day on Wednesday they'll be available, or they might be available, what time would be best to come visit in the afternoon, remembering that we have our orientation probably running until about 2 o'clock, so somewhere after 2 and before 5:30. So let's start talking about the bills. Here are 5 bills. The 2 that are in red are actually the same bill, one in the House and one in the Senate, that you'll be talking about with your legislators down in Springfield. These are the legislators that are responsible for each bill, and we'll just go in order that they're listed here. House Bill 2392, a revision to the Pharmacy Practice Act. This bill would require at least one pharmacy technician to be on duty at all times. It would limit pharmacies, all pharmacies, because it's not specific, to fill 10 prescriptions per hour. That, which, if you think about it, is somewhat unwieldy, is going to be very restrictive. We've spoken to the sponsor, and the sponsor believes that this is going to be 10 prescriptions per hour per pharmacist. There needs to be 10 pharmacy technician hours per 100 prescriptions filled. So if a pharmacy has multiple pharmacists on duty and they're filling 20 or 30 prescriptions an hour, then there would have to be that many technicians available too. It does prohibit pharmacists' participation in advertising or soliciting, and it prohibits productivity quotas. The bill also requires that pharmacists must have 2 15-minute breaks every day and 1 30-minute lunch break every day if the pharmacist works at least 7 hours. One of the catches is, and I believe it's a bullet point on another slide, is that it limits the length of a pharmacist shift to 8 hours a day. Making the pharmacist work during their break requires the pharmacy to pay triple time for that day, and for the whole day, even though it's only over the break that they would have to work, which means that pharmacists would not be available for emergencies, or it would be a huge financial impact to the pharmacy itself. Pharmacy must provide at all times a room on the premises with tables, chairs, and a clean and comfortable environment. The pharmacy must keep records of all breaks for the pharmacist, so that means probably a running logbook or online log. And again, like I said, every pharmacist shift is limited to 8 hours, so the 7 on, 7 off shifts on third shift, or even some hospitals or some pharmacies use that on second shift, would not be available. The 4 10-hour days shifts would not be available anymore either. And then finally, this bill would require that error reports must be kept and maintained in the pharmacy. Problem with this is that these are all available for discovery for civil or criminal prosecution. So let's move on to House Bill 3833. This bill is a precursor to pharmacist provider status in Illinois. It just defines a pharmacist as a healthcare provider in those acts that are listed there. These are all acts that have healthcare providers listed as physicians, nurse practitioners, physician assistants, etc. This would just list the pharmacist as a provider also, so that later on, when the pharmacist wants to get paid for services, this act would allow that to occur. House Bill 274 is a bill by Representative Michelle Mussman from Schaumburg. It revises the definition, in the definition of pharmacy practice to allow for prescribing and dispensing of hormonal contraceptive patches and hormonal oral contraceptives. The pharmacist has to complete a standardized training in order to be able to do that, and the pharmacist is required to provide the patient with a self-screening risk assessment tool prior to the dispensing. This bill was introduced last year. It met substantial resistance from the medical society, even though I can't remember the exact name of the organization, but the national group of obstetricians and gynecologists support oral contraceptives being over the counter. So, also, the pharmacist must refer a patient to a primary care practitioner or women's health practitioner after prescribing these medications. They have to provide the patient with a written record, what's been dispensed, so that they can provide that to their practitioner, their physician or other healthcare practitioner. And the pharmacist may not continue to dispense these products if the patient fails to consult with a physician or other women's health practitioner within 3 years of initial dispensing. So it does require the pharmacist to keep track of that and be in tune with what the patient is doing. House Bill 3285 and Senate Bill 1844 are both bills that they amend the Illinois Insurance Code and allow for medication synchronization. This is basically a partial refill of all medications to get all their renewal dates or refill dates on the same time. It's a convenience for the patient. It does incur a cost for the insurer, but a minimal cost. Insurers are not allowed to prorate the dispensing fee. They are allowed to prorate the cost of the medication. And both these bills also set standards for and rules for pharmacy audits by pharmacy benefits managers. They also prohibit insurers from projecting overpayments to pharmacies and requiring an actual proof of overpayment. Currently, there are no regulations on audits, and many of the audits that are performed by pharmacy benefits managers or their agents find discrepancies where the pharmacy is charged too much and then projects that cost out further based on the number of prescriptions they've filled. This would prevent that and say you need to actually prove what you're asking for back in overpayments. It allows the pharmacies to use electronic medical records of hospitals or prescribers to validate refill information or authorization, and PBMs may not recoup payment claims from the pharmacy, which is identified through an audit as the responsibility of another payer. So in other words, a PBM can't get money back that they didn't pay in the first place. With these two bills, again, they also prohibit the conducting of an audit. Excuse me for a second here. Well, I'm just going to read it to you because this is not clear to me. Neither the agency conducting the audit nor its agent shall receive payment based on the percentage of the amount recovered. Okay. So in other words, you can't use payment incentives for the people doing the audit. The more they find, the more they get. and the same is true for employees of the PBM itself that's conducting the audit. And interest shall not be charged during the time of the audit on overpayments. However, once the overpayments are identified, the PBM or the insurer can charge interest. So before we go on to some other bills, and there are quite a few other pharmacy bills that we won't have time to talk about in Springfield, but you need to know about, let's go over some legislative do's and don'ts. First of all, with the do's, make sure you wear your white coats as students. If you're faculty members, you're certainly encouraged to wear a suit and tie or business attire for the ladies. Guys that wear the white coats, make sure you wear a shirt and tie underneath. Ladies, a nice business blouse would be good. And then once we're down there, always be polite to the legislators, act engaged. Well, I'll get to the don'ts here in a minute. Volunteer to lead the discussion with your own legislator if you're comfortable. However, if you're not sure of the talking points and you're not at ease in talking to someone that you just met at that moment, then let the leader go ahead and lead. Every group will have a veteran leader who's done legislative day before, and so it shouldn't be a hardship if you're a little bit shy. On the other hand, it's a great opportunity for you to step forward if you're ready. Stay close and listen to your group leaders. There will be a lot of people down in Springfield on Wednesday. We don't know what groups are going to be down there yet, but there certainly will be several, and so it gets crowded in the Capitol, and as you're walking through the hallways, it's easy to get separated. So hang tight with them, and you'll have a great day. Here's some don'ts. Don't wear jeans, please. There will be groups down there in jeans and T-shirts, and that's fine, but they don't represent professional organizations or professional healthcare professions, so that's important. Don't threaten your legislator, even if you want to. If they say something that just boils your blood, it's time to stand back and just be courteous at all times. Don't sneak off to study. That has happened in the past, and it's very embarrassing to see students in white coats sitting in the hallways reading books and notebooks and so forth. They're looking at laptops and not walking around talking to the legislators. Whatever you do, don't start your conversation as a voter and a constituent. They'll be able to tell by your age that you're old enough to vote, and you can let them know you're a constituent, but saying as a voter and a constituent, that sounds condescending and will immediately hit some resistance. Don't roll your eyes or make nasty remarks when they say something you disagree with, and from time to time they will, especially if you speak to the sponsors of some of the bills that we are not in favor of. On legislative day, please eat your lunch quickly. We have limited space in the Howlett building for lunch, so there will be 3 shifts. Maybe this year we'll get away with 2. But either way, you will have limited time for lunch, so please eat quickly and then head back into the auditorium. We will go over the talking points one more time. I know that Garth Reynolds from IPHA has been on all the campuses, or will be on all the campuses ahead of time, talking about these issues too. So this, by the time you get to Springfield, this should be pretty well ingrained in your mind. So learn as much as you can while you're down in Springfield. There's a lot to be seen and a lot to be learned, but enjoy your day. Make it a positive experience if you can, and if it doesn't go that way, then let us know, and we'll try to fix it as fast as we can. So here's a cadre of other pharmacy bills that we're gonna that you may get some questions on while you're down in Springfield, but we don't intend to talk about them for many reasons. One reason is that many of them don't have a chance of passage. 2, some of the bills are not that significant and don't carry as much weight as the 4 that we talked, or 5 that we talked about earlier, or 3, they're just, again, not that important. So there are 2 bills that are identical, Senate Bill 73 and House Bill 239, and these are the two senator and the representative who are bringing these bills forth. They would require pharmaceutical manufacturers of brand name items to notify both the Department of Healthcare and Family Services and the Illinois Department of Public Health and the General Assembly and any insurer of price increases of more than 10% or more than $10,000 in a 12-month period, require them to notify at least 60 days in advance of that price increase. This bill also talks, or these bills also talk about to generic manufacturers for the same principle or the same concept, except that if their price increase is 25% over the price or more than $100, that 60-day prior notice must be given. And within 30 days of the increase, report on the justification of the rate increase or price increase is required. It also requires the manufacturer to provide the previous year's marketing budget for both brand name and generic drugs, and the date and price of acquisition if the drug was not developed by that manufacturer. So in other words, if one brand name manufacturer buys a product from another, and we could even go talk about EpiPen as an example of that, then the manufacturer would have to provide the date and price of acquisition of that drug when they bought it, and then along with the notice of price increase. Senate Bill 625, Senate Bill 642, and House Bill 312 all amend the Nurse Practice Act, and actually there's several other ones that amend the Nurse Practice Act, but these three have one thing in common. They remove the requirement for written collaborative practice agreements for APNs in general. They require a written collaborative practice agreement for new grads until they've obtained 3,000 hours of experience. But our concern is, the pharmacy's concern is that if the written collaborative practice agreement disappears, then pharmacies will have no way of knowing what the nurse practitioner can prescribe. Senate Bill 902 and House Bill 346, they're both revisions of the Pharmacy Practice Act and its sunset date. Both of these bills have other changes. I believe both of them come from the Illinois Department of Financial and Professional Regulation as their cleanup bill to the Practice Act. For those of you that are not aware, 2017, the Illinois Pharmacy Practice Act sunsets, which means every 10 years the bill has to be, or every professional regulatory act has to be reviewed for it, whether or not it's necessary anymore. And as you can probably guess, pharmacy certainly needs to continue to be regulated as a profession. So this is our year to renew the Pharmacy Practice Act. It's also the year to renew the Nurse Practice Act and the PA Practice Act. I believe even the Medical Practice Act is up this year. It does remove the mandated number of pharmacy investigators. Right now, the department is statutorily required to hire or to employ at least 4 regulators, investigators for pharmacy, and currently they have 5. This is the most they've had in many years, and it's the first time they've actually met the state requirement, and that just happened in the last year. That also adds a requirement for email addresses of all license applications and renewals. So that has been a field that was added a few years ago as voluntary. It would now make that mandatory that that field be filled out. I suppose if you don't have one, you can't put one in, but it's very easy for everyone to get one of those nowadays. Senate Bill 1604 is a very interesting bill. Senator Chris Nybo of Lombard, and according to our lobbyist in Springfield, Jim Owen, this is because of a personal experience that the senator had. He went into his pharmacy to get a generic medication, chronic medication that he takes filled. It was back ordered by the distributor, probably back ordered by the manufacturer too. So the pharmacy dispensed the brand name product and of course charged him the brand name price, and he felt that that was unfair to him. Our lobbyist Jim spoke with him and said, but changing the requirement to make the pharmacy dispense the brand name drug at the generic price would really then punish the pharmacy for something that was out of their control too. So Senator Nybo has indicated that he's going to hold this bill until he can find a more suitable alternative to this. Senate Bill 1790, Senator Steve Stottleman from Rockford, Illinois. This would allow a pharmacy to refill a prescription that has run out of refills without prescriber authorization if the pharmacist can't reach the prescriber in a reasonable amount of time. So when that patient orders their refill on Friday afternoon and the physician has already left the office and won't be back till Monday, the pharmacist can go ahead and have permission to fill this and let the prescriber know at their earliest convenience. It does not include refilling controlled substances, so it's not everything, but chronic meds, this is a great alternative. Another bill from Senator Nybo, Senate Bill 1944, currently in its current state, repeals the Hypodermic Needle and Syringe Act. And what this would do would remove the allowance of pharmacists to sell up to 20 needles and syringes without a prescription. This is a little bit concerning for us, for pharmacists, because I think pharmacists should be able to do that, to be able to dispense needles and syringes without a prescription in a limited quantity. Senator Nybo, in the same conversation that he had with Jim on Senate Bill the 1940, I think, or 1904, whatever, did indicate, though, that he intends to revise this bill, amend it, and in fact increase the amount of syringes and needles that a pharmacist could sell without a prescription to 100. We haven't seen language on that, so we won't talk about that, but we want to make sure that the Hypodermic Needle and Syringe Act does stay in place, or that there is some mechanism for a pharmacist to dispense needles and syringes without a prescription for those patients who may need them. Senate Bill 2011 would amend the Controlled Substance Act, would allow for partial filling of a C2 upon the patient's request. It does require that the pharmacist notify the prescriber within a reasonable amount of time, but no later than 7 days from a partial fill. And if a patient says, well, the doctor wrote for 30 Percocets, and I really think I'm only going to need 15, that's fine, but then the pharmacist can only dispense 15 and the remaining quantity may not be refilled, even if the patient requests it. Senate Bill 2056, Chapin Rose from Champaign, requires that all prescriptions for medications or devices must be electronically transmitted to the pharmacy of the patient's choice by January 1st of 2022. This is an important bill from the perspective of it would simplify the process of prescribing and the transmittal of the prescription. It would remove all handwriting from the process, but at this point we believe that it's probably a little more ways off than that because current systems are not complete. Not all prescribers have electronic systems. Not every pharmacy has a mechanism to receive electronic prescriptions, although they're beginning to be less and less. House Bill 2742, Representative Mike Zaleski, would require pharmacies to implement systems that receive medication discontinuation orders, primarily electronically. Right now, if you think about it, when a physician changes a patient's medications, rarely do they write on the prescription, DC the previous med, whether it's the same medication, different strength, or whether it's another medication in the same group or a different group, say changing from an ACE to an ARB, or changing the strength on a anti-diabetic medication, rarely does the physician write discontinue the other. And currently electronic systems for prescribing and receiving prescriptions have that capability. However, they need to be certified. It costs money to certify these systems, and so therefore there needs to be a mechanism for the pharmacy and the prescriber to recoup their costs related to this. It asks the department to create rules to prevent discontinued meds from being dispensed by automated systems, and that includes automated refill systems. Senate Bill 1546 and House Bill 2957, both are the same. This allows for pharmacy prescription synchronization also. I believe these bills we talked about on our top 5 bill list, synchronization as part of a PBM regulation bill. This is strictly a synchronization bill. These were put forth by the Illinois Retail Merchants Association. And again, they're very similar. They prohibit the insurer from prorating the dispensing fee. They do not prohibit the insurer from prorating the cost of the medication. Senate Bill 1971 and House Bill 3572 talk about creating a maximum allowable cost list for each PBM for drugs, and the PBMs would have to follow that list. And it also prohibits PBMs from reimbursing pharmacy for less than their costs on the medication. And it does create an appeals process for pharmacies. This bill is it is a PBM regulation bill. However, we're not sure what group is pushing this or supporting this bill. It is not IPHA, ICHP, or the Illinois Retail Merchants Association. So with that, I'm going to unmute the phones, and if there are questions, if one person from each site could relay the question to me, I'd be happy to.
The conference has been unmuted.
Here we go. I would be happy to respond to any questions that you might have. Does anybody have any questions at all? Okay. Well, I hope that I see that we have UIC Chicago is on, UIC Rockford is on. I have a 6-3, that looks like Midwestern is on the phone. And we're glad that you could make it. This will be posted shortly this afternoon on the ICHP website, so please direct any of your fellow classmates or students in other classes at your school to listen to this if they're planning on going to Ledge Day and couldn't make it to this presentation. We look forward to seeing you down there. In the last count, we were at about 250. Unfortunately, that's kind of low for a legislative day for us, but the good news is there seem to be quite a few pharmacists this year, which is a good thing. And we're always happy when the students are in the house, so to speak. So, any questions? I didn't do that good. I know that. All right. With that, I think we can all sign off, and hopefully you'll see this online. You can refer your folks to it shortly. And we look forward to seeing you all down at Legislative Day. Thanks.